I'm Merril Chair of Save Our Hospitals. My address is the same address as is used for Save Our Hospitals, 7 Kimball Gardens, London, SW6 6QG.
My name is Jim Grealy, same address, 7 Kimball Gardens, SW6 6QG, and I'm the Assistant Secretary at the Save Our Hospitals, Hammersmith and Charing Cross.
I think voice a little louder, please.
Okay.
Sorry about that.
Sorry about this.
Bearing in mind I can see everybody else.
Okay.
If you could just repeat it for a driver.
Of course. Yes. My name is Jim Grealy. I'm the Assistant Secretary of Save Our Hospitals, Charing Cross, and Hammersmith, and my address is 7 Kimball Gardens, SW6 6QG.
Okay, sorry. Yeah, thanks, Peter.
Could I ask you please to look at, first of all, Bundle 3, Volume 3, and if you could turn please to page 1178. That is a document from Charing Cross, Hammersmith, Save Our Hospitals. First of all, can you confirm that that's your submission?
I can confirm that, but I apologise for some of the typos I found yesterday.
Don't worry about that. Subject to the typos, can you confirm that it's true and accurate to the best of your knowledge and understanding? And you wish that to stand as your evidence to the Commission?
I do.
Can we also turn very briefly, there's another bundle in front of you, Bundle 4.
Yeah.
And if you turn please to page 1439. There is another short document there. I think that's Miss Hammer only. Can you confirm again, is that your submission?
It is a personal submission, yes.
And also true to the best of your knowledge and understanding, and you wish to stand as evidence to the Commission?
I do indeed. I could almost add to it.
I'm sure you'll have time to in due course. Could I ask you first, in your non-personal capacity, your Save Our Hospitals capacity, for some views about the consultation phase of events? First of all, can you help with, very briefly, with your involvement in the consultation phase and your experience of it?
My involvement was more limited because I had to be back in Australia looking after my mother who had had a fall. But what I do know is that, and this partly includes me, that a very large number of the local population did not, only found out about the proposals coincidentally, that many of the public meetings were meetings where it was very hard to get local views heard and where it gave very clearly the impression that it was pretty much pre-decided. I have to say that the written consultation document actually had closed options, which meant that there wasn't space to raise a whole lot of issues that people had about the proposals.
Did you, in your attendance at your knowledge of public meetings, were you able to form a view as to whether or not all sections of the population, there were representatives of all sections of the population, or did you feel that some may have been excluded or were not represented?
I think that's very hard to actually assess if you weren't at a wide range of meetings. What I do, probably minority ethnic groups were underrepresented even when the consultations were in parts of the borough where they would be, where minority black people would be the largest percentage of the population. Certainly the meeting that I attended at Phoenix School was significantly underrepresented by a range of ethnic minority groups. I think almost more to the point was the way that those meetings were structured, that it was extremely difficult to raise the sorts of questions that local people actually wanted to ask.
Pause there for a moment, Mr. Grealy, I see you want to come in.
Yes, one or 2 points I would like to ask, and to add to what my colleague said, and that is that some of the meetings were very, very badly advertised. Were one not part of a circuit of people who were interested in public health, one would not know the meetings were taking place. And I do recall one meeting at the Hammersmith School, chaired by the then Director of Finance for Merril, Mr. Bill Shields, when he was asked about the limited circulation of knowledge about a public meeting, he quite simply shrugged and said it had nothing to do with Merril. And I do recall going into that meeting where there were a number of customer services people, if I can put it like that, with a pile of documents much higher than these, who wanted anybody who came into the meeting to sign up for membership of Merril there and then. But that was an evening where, going into the meeting, the staff at the door did not know the nature of the meeting into which they were admitting people. So in terms of willingness to consult, it was quite the opposite. It was customer sales rather than consultation.
Just pause for a moment, because your colleague was telling us about what she felt were the difficulties in local views being held. Can you just amplify a little bit how those meetings took place and what it was that you say that caused difficulty in those views being given airspace, if I can put it that way?
The one meeting I was able to attend, it was a platform.
I think Mr. Grealy has turned his off, so you can turn yours on. Yeah.
The meeting that I attended, there was a platform of speakers. There was very little time for speakers to speak from the floor, and interestingly, a number of those speakers from the floor were actually medical people who seemed to have had sort of prior conviction, if I can put it that way. In other words, there wasn't the space for an adequate debate about the issues. I don't think that sort of public meeting anyway is the way to actually get at the views of people about their health services.
What should have been done in your view?
First of all, people should have known much more about it. Secondly, there should have been a different sort of discussion forum, I think, to actually enable people to express their views. And I have to say that the CQC's meeting, although rather limited prior to the inspection of Merril, was a better mode of actually hearing what people had to say, because it spoke to people one-to-one and allowed the space for people to raise their issues.
Now, just in terms of the basic premise of the consultation that was put to the public, can you help with your view about whether the premise of reduction from 9 to 5 major hospitals was in wide enough ambit or not?
I'm not quite sure what you're...
There was a pre-consultation stage at which a number of options were whittled down to 3 options which were placed before the public. Those options were all premised on the reduction of acute services in 4 out of the 9 hospitals. And what I'm seeking to ask you is your views from your campaigning point of view as to whether or not that was an appropriate way to proceed or not.
I think it's quite clear that we would think it was not least because of the support we have on the street week after week, and by this stage, year after year. It was a pre-decided issue. They even, in the consultation papers, had a preferred option. And it was quite clear they were deriving the consultation to get the answers that they wanted, in other words, to support the preferred option. And as I understand it, a lot of the submissions that were, for example, petitions and so on, which represented thousands of people's views, were counted as a single submission.
Now, I want to move on from that aspect, and I want to ask you about something you've touched on in your submission, borough-wide provision. Just in terms of Hammersmith and Fulham, can you help us with whether there is an even spread over the borough, or is there a discrepancy between provision in different areas? Sorry, rather a long question. And if so, what's behind that?
I'm not sure I could say what's behind it, but I think one of the things Save Our Hospitals did was to actually send round, which I think we have submitted to you, our response to the independent, the review panel.
You're referring to the independent reconfiguration?
Reconfiguration panel, yes. What we decided to do was that we were quite pleased with it, that we ought to let GPs see that, and we actually hand-delivered to every practice, to every GP in every practice, as well as every practice manager, a copy of our response to the independent review panel with a covering letter. The two of us actually did that entire delivery. The part of the borough we happen to live in is in the south of the borough, and it is quite clear that there is a greater density of GP surgeries and GPs in the richer south part of the borough than there are in the north part of the borough, where the GP surgeries, a lot of them are rather run down, some of them are single doctor surgeries, and they're spread further apart. So there are quite clearly differences in the two parts of the borough, and they do relate to wealth.
Could I add to that? One of the factors which we have looked at is the relative affluence between the quite rich south, for the most part of the borough, and the very poor north of the borough. We know that life expectation is shorter, chronic conditions are worse in the north of the borough, yet public health facilities really are very sparse. And in the part of the borough we happen to live in, one has an immense choice of doctor surgeries. In the north of the borough, there are few and far between, and public transport links in the north of the borough between surgeries is not very good. And furthermore, many of the people in the north of the borough are old people who need public transport, therefore they have no choice.
Now, bearing that in mind, and focusing perhaps particularly on that aspect of the population, what effect has the closure of the A&E at Hammersmith Hospital and Central Middlesex Hospital had?
Again, I don't have concrete evidence
from your knowledge and understanding as far as
of that. However, we have had discussions with Healthwatch, and perhaps given some of the earlier comments about Ealing Healthwatch, I have to say that our experience in Hammersmith and Fulham has been somewhat different, that they have been champions of local patients to a very large extent. But Healthwatch themselves have said that attendance at Hammersmith Urgent Care Centre has fallen dramatically. Indeed, it was suggested that should I need some urgent care, that would be a really good place to actually go to rather than waiting for a long time at Charing Cross or at Chelsea and Westminster. So I think one of the things that's actually happened is that people don't know what to do, and Healthwatch again have reported that their evidence is that it's not that people are going somewhere else, but that in many cases people are just not going when they probably do need medical help.
I don't know if you're able to help with this, but do you have an understanding of where they're getting that information from? What's the evidence base for that?
I think they did some research on it.
Now,
I think you'd have to ask them, and I gather you are meeting with them later on.
Now, moving on from that, if Charing Cross Hospital goes down the same route, and Ealing goes down the same route, and the A&Es are either shut or changed in their format, if you can put it like that, again, from your understanding of the situation, what do you say the impact will be on, first of all, let's just take it, the south richer population and then the north poorer population?
I have recently had reason to go to the urgent care centre at Chelsea and Westminster Hospital, and the waiting times there were not good, and I was told it was a good time of day to be there. What I think will happen is that other hospitals will be under huge pressure. Did that answer it properly? Sorry.
Could I add just one factor to that? Because we do campaign in a variety of parts of the borough, and what we do know is talking to people, for example, people who are frail, people who are quite old, mothers with 1, 2 or 3 children, who find it very hard to travel far because of their condition or because of who they're in charge of. They say, if we had to get up to St Mary's or to Chelsea Westminster, we just could not manage it. And they add significantly that were they to go and seek help and then have to travel home afterwards, often people of low income, they simply could not afford taxi fares. So what we draw from that is that people would only go to travel a great distance if they were certain they really were in a very bad condition. But people tell us they're not trained medical staff, so they don't know how to self-analyse. What happens thereafter, I would like the local CQC to explain to us. CCG.
Can I just ask you a little bit about the waiting times? Now, you've attached to your submission, I think it's at page 1197 it starts, you've attached some graphs, and perhaps without going into huge detail about it, if you could just take us through what those graphs mean.
Someone else has done the graphs, but
They've done them very beautifully. I'm just wondering what in broad terms that actually tells us about what's going on now.
I think what's key, I think what's key in terms of the graphs is that at a certain point, not everyone can see it, but there's a vertical orange line. That's the point at which the 2 A&Es closed. And what you see are the meeting of the A&E waiting times being failed, falling below the 95% requirement.
This is the 4 hour.
Quite dramatically, yes. I think there's other interesting information in these graphs, because much has been made in the press about the fact that this has been an England-wide phenomenon. The actual graphs show that this isn't the case. To the extent that there was a national problem, that is certainly reflected in this area, but if you disaggregate the information, you actually find that North West London Healthcare NHS Trust has failed dramatically, that Imperial Healthcare Trust has failed pretty badly, and if you take those figures out, that London was doing better than England as a whole. So that there's been a significant local effect in terms of the closures of those 2 A&Es on hospitals actually meeting the required 4-hour waiting time requirements.
Are you able to help with whether or not that's something which is changing now that we are coming out of the winter period into spring, or whether that is a continuing situation?
The information that I have is that it's a continuing situation, but with possibly some amelioration.
Now, I just want to move on and ask you a little bit about the standards at St Mary's and the Chelsea and Westminster Hospital, because we have CQC assessments of those. Do you have any comment that you wish to make about those and about the use of the services there?
I think one of the things we wouldn't want to do is to sort of put one hospital against another hospital, but at the same time, we do have to say that it is quite astonishing that the hospital that has become the prime location for most of our care in the future is to be St Mary's, which has failed quite dramatically in much of the CQC inspection, whose A&E, not just for the cleanliness issues, but on a range of other issues, was deemed to be inadequate, that it is to be the preferred A&E rather than Charing Cross. At the moment, Chelsea and Westminster has been doing reasonably well in terms of meeting demands, but what happens, of course, when you lose the other A&Es, who knows?
Can I ask you please now to turn on to thinking about the out-of-hospital services?
Yes.
There's a bundle in front of you marked Volume 2, and I'd like to turn please to page 586, and that should be a letter from the Hammersmith and Fulham Clinical Commission Group.
Yeah.
I think it's at the, sorry, bear with me just 2 seconds. At the penultimate page of that letter, there is reference made to initiatives taking place for out-of-hours hospital services. I wonder if you could just take a moment to scan that and then tell me whether or not you recognise or are aware of any of those initiatives having come into play.
Sorry, can you tell me which
page?
section
Beg
it's
your pardon, let me just-
under?
That's which page?
It's volume 2 and it starts on page 585.
Yeah.
And then if you go through it over the page to, I think it's 589,
Yeah.
and it starts at, 588,
Ah.
providing integrated services.
Yep.
In fact, slightly before then, in fact it's 586, it starts at paragraph 2, investment in out-of-hospital services. And I'm certainly not asking you to read all of it, but just simply to flick and see if you recognise any of those initiatives as being things that you are aware of taking place at the moment.
I actually don't think that we need to read it because we have been following the CCG actions. Indeed, we're at a meeting last week where I did raise questions about out-of-hospital services. Yes, we are aware of the initiatives, but we're also aware that there is no evidence that those initiatives will reduce the need for hospital beds. Indeed, and this is not my evidence because it only happened last week, at the CCG, in the small number of minutes they allow for people to raise questions, I raised questions about out-of-hospital services. I asked it particularly in relation to whether they could provide prevalence evidence that they would reduce significantly the numbers of people needing hospital beds so that they could justify the closure of the beds in hospitals. Dr. Spicer answered me by saying, shaping a healthier future isn't about reducing beds. I really can comment no further on that point, but when pushed on prevalence studies, he mentioned one study in Manchester that wasn't actually about prevalence, but was about setting up out-of-hospital services, and mentioned one study about prevalence in a very similar area, of course, to ours, Torbay, as showing that it would reduce hospital admissions. One of our problems is we actually think these initiatives are good. We're not opposed to these initiatives, but we want the evidence that they can justify closing down our major acute hospital services safely by actually increasing the out-of-hospital care. I don't think they have ever provided that evidence we have been asking for 2 years.
Could I add to that? One of the significant facts I think that we face, or difficulties, is quite simple. When we ask about the study, when we ask the CCG with detailed questions, and we really do have our research done up when we go to meetings, we're told that things are happening which actually do sound very good. But when we ask questions about numbers involved, they're both very reluctant to answer, and when informally people answer afterwards, the number of people involved in each of the initiatives really is tiny, and the initiatives which they talk about we would love to see expand, but in terms of the need of people in this borough, it really doesn't approach the problem, and to put it as a success indicator for what's been done is as misleading as you could possibly do.
Thank you. As I said, I have no further questions. If you wait, the Commissioners may have questions for you.
Yes, I've got a specific one just to pick up. And it's in your paragraph 5, 1. It's really the assertion that there's a need for co-location. That's trauma and stroke. Also, I have a bigger question about the merit of specialist units as against all A&Es having the same standardised range of provision as an alternative model. So if you could comment on that.
I think as a campaign group, we fully accept that there is clinical evidence that for a certain number of very specific conditions, it is important to have that sort of concentrated medical help. And therefore a HASU or a trauma centre needs to be located somewhere where there's good access across a number of hospitals and a number of areas. But as you'll know from our submission, we have actually met with Imperial Health Trust. We have asked Imperial Health Trust on both occasions that we met them what the clinical evidence is for basing a HASU and a trauma centre, co-locating them, and they haven't been able to provide that evidence. Now, it might be true, but we'd love to hear the evidence. That for us is one of the big issues, that we ask questions. We don't think they're stupid questions, but we can't get answers. We can't get answers of the clinical, the scientific evidence that back up their assertions that you need a trauma centre and a HASU together. And when you point out that just down the road from St Mary's there is a HASU that does not have a trauma centre with it, I mean, the answer is sort of like that.
Just a note to that. I'm unsure what's going to happen to the regional neurosurgical centre that is Charing Cross, because that's why there's a HASU there. Because there's a cross, I presume, there's a cross-fertilisation between, for example, interventional radiology, etc. I don't know whether you were able to learn anything about that.
I think all we've learnt is that there's going to be 24 overnight beds instead of 360, and what they're going to be used for and how they relate to other services is as clear as mud, I'm afraid, at the moment.
Can I amplify that? We have met twice over 5 hours with the Imperial management. We do attend CCG meetings as well as Health Watch meetings, and we have asked questions about this. And I think what's most troubling for people we meet in the street and our campaigners is something straightforward. We're told that the vision is right, but when we ask what it is that's going to be in Charing Cross when they open a new hospital at a rather large expense, they actually are blunt. They say, we don't know. So they know the general plan will work, but they really have not planned out the specifics, and under pressure they will tell us that. But there's a second string to it, and that is that each time we ask, we're told that they're bound by shaping a healthy future, which really was a product of an earlier body which no longer exists, and that there's no one body responsible who can take decisions. And we've been told that, for example, by Dr. Tracy Batten, the CEO of Imperial, when we pointed out that we thought rethink was needed on some parts of the plan or the whole plan. We were told to go and ask the CCG because their secretary Mr. Oakley's was leaving soon. But the CCG said, no, it's not their responsibility. So as a patient, a local resident, and I've been a patient at local hospitals, it's impossible to work out who is in charge, or who's in charge of what. Or, if things go wrong, who will take the buck?
Seems to be a matter of faith. Just final thought, how do you manage to get it in to see Imperial when the Edinburgh and Hammersmith and Fulham can't?
A challenge in one of their board meetings when they kept failing to answer questions, and I leapt up and invited them to meet with us, and much to my astonishment they agreed.
Yes, I'm just thinking about these initiatives that keep being mentioned, and obviously Torbay as the example is used everywhere. Torbay, incidentally, for those who don't know, is actually falling apart now because the components that came together are going in their different directions, and it's no longer running along the same line. So even there, it presumes a certain continuity of effort. But to what extent do you get the impression that these initiatives are taking place? You mentioned small numbers, and I think that's definitely the case. And restricted time, and they're normally over a restricted time. Do you get the impression they're also given additional resources and preferential spending compared to what might be available?
Certainly temporarily they get extra resources, but they are pilots. They talk about them as pilots, and there's never any talk about implementation should the pilots be successful and how that will be funded. One of our questions has also been about who will fund out of hospital care, because at the moment hospital care is paid for through our taxes. Are we going to have this as means tested sort of care? How long will it continue? A lot of the pilots are for periods of 10 days or 6 weeks, depending on which particular scheme that they're looking at. So basically the answer is no, we don't actually have any sort of clear idea of anything in terms of how it's going to be instituted.
Has anybody come up with any suggestions as to how it might be at the same price or cheaper than the current balance of care?
I think there's one very important factor to look at here, because we have asked the question of Imperial and the CCG about paying. Currently, everybody in the country is treated free as part of the NHS, and the most recent pilot were shown at the Health Watch lasted for six weeks. It sounded very good. At the end of 6 weeks, you pay. And we were told, frankly, that was the case. And people who need, at the end of 6 weeks, for further treatment, either have to admit themselves to hospital or persuade their GP to send them back in, or to pay. And when we've asked questions about payment, time after time, people become very evasive. And this is particularly worrying because this very week, the chair of the local CCG told his members, that's Dr. Spicer, that what's happening in this part of London, northwest London, is, I'm quoting him now, is a pioneer for England as a whole. If what works here is going to be rolled out everywhere. But we're in the dark as to what would work and what would not work.
Another word for pioneer is guinea pig.
Well,
But I mean, do you get any impression that there's information there to suggest whether or not these services might, as they claim, save money? Because overall we've got the context of £1 billion of savings that they're looking for out of this reorganisation.
I personally cannot see that the pilot schemes that we've actually been to briefings about can possibly save money, particularly if they're going to be on the sort of scale that will be required if you're going to actually close down hospital wards and remove beds.
Again, let me just add one little fact to that. At the January CCG meeting, a number of initiatives were looked at, and we were told the budget will stretch to 16. And thereafter, they don't know what will happen. So what actually does look like a small set of quite good initiatives, the funding thereafter is not at all clear. But there's one other factor which we haven't touched on, it's in our paper, and that's the relationship between shaping a healthy future and mental health. And when we broached this with the Imperial management, they were quite frank that the local mental health trust would not cooperate. And at the January CCG, the vice chair of the CCG, Dr. Susan McGoldrick, said with some passion, in fact, the West London Mental Health Trust is the worst trust with which they've ever dealt. And given that we'd already been told that 20 to 25% of those who present at A&E have mental health conditions, this for us is very worrying indeed.